This presentation on evaluating and managing patients with type 1 diabetes on automated insulin delivery systems is prepared by Dr. Hussein Abudrad. Automated insulin delivery, or AID systems, generate thousands of distinct data points every single week. For a clinician facing a standard 15-minute patient encounter, processing that volume of raw information is a logistical impossibility. To make this data actionable, we rely on the Ambulatory Glucose Profile, or AGP. This is a standardized, single-page report that aggregates 14 days of continuous glucose monitor metrics into a clear visual format. Interpreting the AGP requires a highly structured approach. By synthesizing the current American Diabetes Association standards of care with Canadian clinical guidelines, we can establish a definitive, three-step practical workflow for every AID patient visit. Applying this specific sequence forces us to validate human inputs before we touch the software. It stops clinicians from making premature adjustments to the pump's algorithm when the actual root cause of a patient's hyperglycemia is behavioral. This workflow diagram begins with step 1, reviewing the glycemic vital signs. We have to assess the core targets on the AGP to understand the patient's baseline control. The primary metric is time in range, or TIR. Our goal is for the patient to spend more than 70% of their time in the target range, specifically between 3.9 and 10.0 millimoles per liter. Sustaining this level correlates directly with an A1C of roughly 7%. We do not need to reach that 70% threshold immediately to see results. An absolute increase in time in range of even 5% is clinically significant for the patient's long-term outcomes. While pursuing higher time in range, we must monitor the primary safety parameter, time below range. The time a patient spends below 3.9 millimoles per liter must be kept strictly under 4%. Within that safety margin, we look closely at severe hypoglycemia. Any time spent below 3.0 millimoles per liter requires immediate clinical attention and must remain under 1% of the total 14-day profile. Next, we evaluate the coefficient of variation, or CV. This metric quantifies how widely the patient's glucose levels swing throughout the day, and the clinical target is less than 36%. The CV is highly predictive. Elevated variability values tell us the patient is at a significantly higher risk for future episodes of severe hypoglycemia, even if their current averages look acceptable. By mapping these specific metrics, we isolate the problem. The variance bands dictate exactly what we need to solve for in the next step, whether that is isolated hyperglycemia, dangerous drops in blood sugar, or sheer instability. Moving to the middle section of the diagram, we reach step 2. Before altering a single mathematical setting in the pump, we must determine if the system is actually being used as intended. We check the time in automation, which tells us how often the pump is operating in closed-loop mode. For the algorithm to be effective, this must be sustained at 90 to 95%. Frequent gaps in wear consistency cut off the data supply. Without a continuous stream of sensor readings, the pump is forced to revert to manual mode, neutralizing all automated adjustments and leaving the patient unprotected. When analyzing user behavior, we look at bolusing. Across all AID platforms, the number of user-initiated boluses per day is the single most powerful predictor of optimal glycemic outcomes. Timing those inputs is equally critical. For the insulin to peak at the right moment, patients must deliver their pre-meal boluses approximately 15 minutes prior to eating. Despite advances in automation, current pump technology cannot accurately detect a meal's composition. All current AID systems still rely heavily on the user's manual carbohydrate counting to calculate prandial dosing. If a patient is routinely missing their post-meal targets, inaccurate manual carbohydrate entry is the most common root cause. We also assess how the patient handles physical exertion. We need to verify if they are actively utilizing specific activity or exercise modes to temporarily raise their glucose targets and prevent exercise-induced hypoglycemia. Finally, depending on the specific hardware, we verify that sleep and overnight mode features are appropriately scheduled to manage nocturnal insulin delivery. If the pump is spending half the day in manual mode and the patient skips pre-meal boluses, changing the basal rates won't fix the problem. Algorithmic adjustments made over a foundation of core behavioral data will fail in real-world applications. Once behavior is validated, we move to the final section of our diagram, optimizing the technical settings. This is where we adjust the specific levers of the algorithm based on the patient's glucose trends. The most impactful lever available to the clinician is the correction factor, or insulin sensitivity factor. Adjusting this parameter improves overall time and range without triggering a corresponding increase in hypoglycemia. To calculate a strong baseline correction factor using the Canadian standard, we divide 88 by the patient's total daily insulin to get the value in millimoles per liter. Keep in mind the inverse relationship inherent to pump settings. Inputting a lower numeric value for the correction factor tells the algorithm to deliver a stronger, more aggressive dose of insulin to bring high blood sugars down. We then contrast this with the insulin to carbohydrate ratio, or ICR, which directly affects postprandial glucose levels based on the food consumed. Tightening the ICR can help flatten out post-meal spikes, but it comes with a trade-off. More aggressive ratios inherently increase the risk of driving the patient into time below range. Lastly, we review the basal parameters. Optimal outcomes are generally seen when basal insulin makes up between 50 and 60% of the total daily insulin over a 24-hour period. If a patient requires tighter overall glycemic control, the programmed basal rates can be aggressively set 10 to 25% higher than the volume the pump is currently delivering. This establishes a strict clinical hierarchy. We optimize the correction factor first because it is the safest lever to pull, only resorting to aggressive ICR or basal rate alterations once we understand the patient's tolerance for hypoglycemia. Zooming out to view this entire diagram, we see that the three-step technical optimization loop provides the mechanical framework. But managing type 1 diabetes requires integrating this math with the patient's broader physiological reality. Because pump users receive rapid-acting insulin exclusively, they face an immediate risk of diabetic ketoacidosis. If an infusion set occludes or the site fails, insulin delivery stops and ketosis can develop in hours. This risk profile changes if the patient is using adjunctive SGLT2 inhibitors. These medications increase the absolute DKA risk by roughly 4% per year, frequently presenting as euglycemic AKA, where glucose levels appear completely normal. We also have to physically examine the patient. Highly erratic glucose readings that don't respond to algorithmic changes frequently indicate site-related absorption issues caused by lipohypertrophy, scarring, or localized skin irritation. The physiological barriers are matched by psychosocial ones. Diabetes distress is highly prevalent, affecting over 70% of adults living with type 1 diabetes. In the context of automated pumps, an intense fear of hypoglycemia is particularly destructive. It actively drives patients to consume unnecessary carbohydrates and maintain compensatory hyperglycemia, completely overriding the system's optimal settings. To capture these variables, clinicians should integrate rapid, validated screening tools, such as the PAID scale for distress or the hypoglycemia fear survey, ideally completed in the waiting room before the visit begins. The AGP gives us the data, and the three-step workflow gives us a structure to act on it. But true AID optimization only happens when we balance mathematically perfect settings with the physical and psychological realities of the human wearing the device.